Good morning, guys.
Morning.
So for this second video, we are going to discuss about the segment. So to start, my name is Nolena Mitimota 180174 from KL.
Okay. I'll introduce myself. My name is Chong Hui Min and my metric number is 179605.
I am Ira. My metric number 180297.
My name is Nanda Sutra Mangat. My matrix number is 178834.
My name is Mary Loria Kongming, matrix number 178685.
My name is Noria Sirapitisha Alias. My metric number is 180538.
My name is Nur Fakrina Hani binti Badruddin and my metric number is 180467.
And my name is Phoebe Simon, metric number 180877.
My name is Delna Mazda. My metric number is 180790.
Hi, my name is Fatila binti Abu Syukur. My metric number is 180045.
Hi, my name is Ililiana binti Kalam. My metric number is 180564.
Okay. So the aim for doing this appendicular skeletal radiography is to recognize structure of appendicular skeleton, describe the position, the strength technique, and you interpret the radiography. Okay, so for the first question.
Before we start for the first question, I would like to describe a little bit about the structure of the long bone.
Yes.
We have the compact bone, which is the diaphysis. In the radiograph, we can see it is an intense radio-opaque shadow. And then the second one is the metaphysis or the epiphysis. You can see it is a spongy bone, and thus it will. We can see it is less radio-opaque than the compact bone. The third one is the joint surface. It has a radiolucent, and then the cartilage will not be seen. And then the last one is the periosteum. It is only visible in case of proliferation, calcification, or ossification. Yep. That's the structure of the long bone. Then anyone want to add before we continue?
You spoke about the metaphysis and the epiphysis, right?
Yes.
Okay, that's the most important part. All right.
Who did the first question?
Diana.
You go file again.
No one?
No one did question 1? Okay, then I'll take question 1. Name and label all the structured organs visible on these radiographs and the positioning of the animal. So, can everybody see the first picture?
Yes.
So this picture is of the forelimb, where we can see the scapula, which is the shoulder joint, along with the humerus head. So in the scapula, we need to be able to identify the acromion, the greater tubercle. The greater tubercle is part of the humerus, the coracoid process, the glenoid cavity, and the spine of the scapula. Whereas in the humerus head, we should be able to see the greater tubercle and the lesser tubercle. So moving on to the next picture, it's a different view, which is the medial lateral view, where we can see the supraspinous fossa and the spine of the scapula along with the infraspinous fossa. So basically one is above and one is below. Along with that, we again see the glenoid cavity. We can see the supraglenoid tubercle of the scapula, and then we move on to the humerus. So you can see the proximal physis of the humerus, the head of the humerus, and all the other little bony structures which are important but too much to name. So I'm not sure if this is the next question or not, but
I think we can do. We share each other what question that you did. Yeah, because
So who had done this question? Anybody here?
Or
No?
I can continue with my part. Okay.
I think we just
Yeah.
go according. Just say what you did.
Okay. so Dana had discussed about the humerus and the ulna and the elbow part. So I did on
Shoulder part.
Huh?
I
Yeah.
said the shoulder
Shoulder
part,
part.
not the elbow part.
Okay, just stop. Okay, it's okay. Okay, so I did on the
This is
slide.
elbow.
Okay.
This is shoulder.
Okay.
Scapula is shoulder.
Alright. So my part is that I did on different not specific body parts, which is on slide 22. So I was asked to describe the radiographic finding. So here on the slide 22 there is two pictures, A and B, both showing ulna and radius. But yeah. So what I found from this picture is there's a difference of density. Even though they are both the same radius and ulna, but both have different radio opacity. While in eye level picture A, there is a radiolucent opacity at the caudal part of the ulna, which is lower part of the ulna has radiolucent, and the B picture has radiolucent at the medial part of the radius. So the opacity is different, even though these both pictures are on the same animal. Okay, so yeah, hello. Okay, so even though it's the same animal but different opacity, so this indicates that it shouldn't be like that. If you are same animal, then you should have the same radio opacity on your own bones. So this indicates that these animal are having panocytis condition, which is the opacity of the bones are different, so it causes the animal to have shifting lameness. So at one time the animal will lame on the right side, or on the other time will lame on the other side or left side. That's why there's because of the difference in the opacity of the bone, the density of the bones are different. This can be caused by due to vitamins deficiency or over too much vitamins inside, so it's not balanced, something like that. So on the slide 23rd is I need to indicate whether normal or abnormal of also radius and ulna. Okay, yeah, you can see. So the bones are radius and ulna, but there's a joint incongruity. The joints are not normally attached to each other. Okay, so we can see that there is a premature closure of the ulna physis at the bottom. There's a premature closure, and then the ulna is not fully attached to the
Humerus condyle.
humerus condyle. And then there is a marked bowing of the radius. The radius are become like not straight, instead bowing, become a bow instead of straight.
It's curved.
Curve, yeah, instead of straight. And then there is a subluxation of humero-ulnar joint. The joint is not, there's a luxation, subluxation, not luxation but subluxation. So okay, next is slide number 24.
You missed out something in slide 23.
What is it?
There's an ununited anconial process as well.
I didn't zoom. Ununited what?
Anconial process.
I see.
Yeah, and all these three findings indicate elbow dysplasia.
Yes, elbow dysplasia. Alright, so next slide number 24. For slide number 24, actually I'm not sure because I cannot find. Anyone can correct me. What I can see is just there's a irregular surface cranial to the metatarsal joint. I'm also not sure what bone is it. There's like there's an irregular surface. I'm not sure is it palisading periosteal or what. Yeah.
Which irregular process is it?
This one.
Okay.
But yeah. Then that's one. This one. Yeah. I also not sure the lower part. What is that?
So basically, when I looked at this X-ray, what I noticed was that the growth plate of the distal ulna and physis hadn't fused yet. So it was a young animal, but because of the irregularity on the caudal aspect of the ulna, as well as you can see there's like a growth on it. And then when you look lower at the distal part of the ulna emphysema, you can see it's a jagged edge.
Yeah.
So it is a fracture, but it's not a clear-cut fracture. Normally when you break a bone, it just there's a very straight, obvious crack, but the fact that this is jagged and you can see bone fragments there indicates that it's a fracture caused by a pathological condition. It's not a trauma-caused fracture. It's a bone pathological condition that has caused this bone to break.
Oh, so it is a fracture.
It is a fracture, but
Okay, I put this here. Okay, next is I do on questions like
I think let somebody else move on because
yeah. You stop at 24, right?
25th.
25th.
Yeah.
Shall we go back to question group 4, 5, 6?
yes, let's do that. Yeah.
Wait, no, should I because mine is 25 and
Oh,
26.
Okay,
let's finish
we'll
that.
finish
Okay,
that,
yeah.
and then everyone just do one slide because we have a very limited amount of time to speak.
Okay. So, as a continuous to what you were saying on slide 25 was the medial lateral projection of the radius and the ulna. And my finding was that there's irregular linear radiolucency in the metaphysis of the proximal and the distal ends of the radius. There's also this irregular linear radiolucency on the metaphysis of the ulna, but only in the distal part of the ulna. And there's also mild soft tissue swelling surrounding the elbow joint, as well as the carpal joint. And then for the medial lateral view and the oblique view, there's actually intercondylar fracture of the distal humerus, and if you look at the oblique view, which is a closer view, there's a clear fracture line passing through the metaphysis, the physis, and the epiphysis. Yeah, so that's my radiological findings for 25 and 26.
Okay. Huyman, do you want to tell us what you saw?
Actually, I think we are now will explain about group 4, 5, 6, which is slide number 10. Slide number 10. Or do you want to focus on slide number?
I did slide number 12, starting from.
Okay.
So,
So everyone may refer to slide number 12.
So from the structure, we can see the proximal epiphysis, the radius, the humerus, the epiphysis of medial condyle, proximal growth of plate, proximal growth plate. The position is mediolateral projection of the elbow joint, but I didn't manage to get the sorry, not on the side.
Anyone want to explain about slide number 13? Actually, we have a lot of slides that we can just focus on slides that we have more understanding.
Yeah.
We should proceed. Just proceed. Yeah. Okay.
Oh, okay. On the slide 17, it's the same as the slide 12, but with radiographic finding is that I don't know.
Actually, I also did the same question, which is slide 17, but I'm not sure about what is the diagnosis for this case. Just that from what I managed to see is that in the lateral view, from the lateral view, I can see there's increased radiolucency in the humerus and also ulna, and in the cranial dorsal view, there is presence of radio-opaque mass distal to coronal process. I'm not sure whether I'm correct or wrong, so I'll just.
It's okay, we all
Okay.
know.
Dr. Lau explained or correct this. And so we are done with group 4, 5, 6. So can I proceed with group 7, 8, 9, which is the structure of the long bone. So from here, you can see ulna and radius, And the question is actually asks us to name and label all the structures visible on the radiograph and also name the positioning. So in slide 19, I would say that this is the medial lateral view of enterobrachium and the animal is on lateral recumbency. Okay, so the next slide is also the same part, which is slide 20, but this view, it is cranial caudal view of enterobrachium and the animal was restrained on ventral recumbency. So I think the structure, I will just keep explaining about it. I will proceed to.
Maybe we can proceed to the next person.
Yeah.
Okay, I read slide 22. Yeah. Okay. From this slide, can you all count how many digits?
6.
This condition called polydactyl. This means the animal has extra digit. Okay, the next slide. Okay, when we look at this picture, we can see at this part there is what's it called? Periosteal reaction. Okay, periosteal reaction is the formation of the newborn in response to injury or other stimuli of the periosteal surrounding of the bone. So there is two classes, non-aggressive and aggressive. Okay, so aggressive, non-aggressive, which is lamina, Conman triangle, and for the aggressive bone lesion is sunburn, spicula. That's all.
Okay, good. Next.
Thank you.
Next. Anyone wants to share?
I think I want to share about the slide 50. Okay. So my finding, I think is UAP, which is ununited anchoring process, because we can see that there is a radiolucent line at the anchonia process, which shows that the anchonia process is separated from the olecranon.
I see.
Yeah. I would like to add some more, which is the cause of bone injury. We can see if there is injury in the bone, we can see there is a decrease in radio opacity, periosteal reaction, change in size and contour, and lastly is change in cervicular pattern. I think that's all from me. Anyone to add some more?
I think I'll add on. If you all see the last slide, which is what is your radiographic findings, the last one, it is on your hind limb, and it's basically the view of a cat placed on dorsal-ventral view, and on the ventral-dorsal view. And what happens is that frog-legged. Yeah, it's a frog-legged position of the ventral-dorsal view. So how do you know if it's a dog or a cat? It's simple. You look at the pelvis. The pelvis, if it's square, it's of a cat. And if you see the abnormalities over there is on your right hand limb, it's actually there's a medial deviation of the tibia and the fibula of the right hind limb. It's supposed to be, if you compare the normal one is the left side. So the right side, there is a medial deviation. That means it's turned to the inside. And what is suspected is cranial cruciate ligament rupture, which causes the position to be that way. And also, there is actually a fault in positioning your animal during radiography. That cat is not square. So one limb looks elongated and the other looks shortened. So that's actually a fault, technical fault.
May I ask if cat is flat, if dog?
Will be wider, the base will be wider.
So for this slide, is the left and right limb different in length?
Yeah, if you see properly, the right looks longer than the left. And the left looks
Is it just like the
positioning or?
because of the positioning.
Okay, allow me to talk on slide 34. Slide 34 is a dorsal plantar view of the hind limb, of the foot. So we can actually label the sesamoid bones located at the metatarsals. From the most medial one is number 1, and then there will be a pair on each metatarsal, so there will be altogether 8 sesamoid bones. And then on the sesamoid bone number 2 and 7, you can see a slight radiolucency, which according to my readings, it could be a fracture. Because in large breed dogs, what I have read is they tend to have sesamoid bone fractures in the sesamoid bone number 2 and 7. So that's why I diagnosed it as fragmentation of the sesamoid bones. And there could be a few factors contributing to this fragmentation. It could be caused by osteonecrosis, developmental issues, traumatic issues, or degenerative conditions. So that would be all.
Can we go to slide number 41? Okay, this is the hindwing. As you can see, this is a staple joint. As what I remember, Doctor said about, Doctor already explained about periosteal and osteolysis center, right? So osteolysis we have aggressive and non-aggressive. For aggressive, we got 3 major important, which is cortical destruction, irregular perosteoblation, and transitional zone. As you can see in this picture, sorry Mira, here we can see permeative osteolysis on this area, and this part like a fracture. Doctor mentioned that on this problem we shouldn't. This is a pathological fracture which secondary due to bone that's not healthy. So we don't have to fix it. Not means like we don't have to do surgery. Just like this. Then other than that, we can see periosteation around this area with Codman triangle. If I'm not mistaken, it's in here. Yes. Mostly for aggressive osteolysis is due to tumor or osteomyelitis, and non-aggressive due to fracture. So it will not split. It's just split.
Anna, would you like to add anything?
I think just want to add something for neoplasia in bone, which is cancer. In a long bone, it's just some information. In a long bone, if it is neoplasia, it either can be in the diaphyseal or metaphyseal location. That's the 2 locations in neoplasia. And then it can be finding, it can be variable, such as aggressive lysis, proliferation, or combination of the both for neoplasia in the bone.
So we have come to the end. So we have discussed about our assignment, we have shared new information, and we also gain more understanding about appendicular skeleton, right?
Yeah.
So I guess that's all. Thank you.
Thank you.
Our next video you did to present.
When next week?